is who we are inside, regardless of age or race, regardless of hair color, tattoos, piercings, or weight. So remember, there's more to beauty than what we see. Beauty is the kindness and the love. Anyone can be beautiful.
Meet Ai. Ai has been working from home for over a year now. She spends hours and hours on her computer working, and to unwind, she often watches her favorite movies. For a while now, she's been experiencing some grittiness, burning, and some dryness on her eye. She notices that she can't stand being in front of her laptop because of the worsening of the symptoms over the day. Aside from this, her eyes were becoming red. She decides to go to her ophthalmologist for answers. By what you're feeling and how your eye is looking and your conditions at work, it looks like you have dry eye. Dry eye, or more specifically for you, keratoconjunctivitis sicca, is a problem of the tear film where there is inadequate production of or an instability of the tear film. The tear film is composed of 3 layers which are secreted by different glands in the eye. Each layer holds an important function to keep the tear film intact. Any abnormality with these can result in dry eye syndrome, as what you're experiencing now. I see, Doc. How is it treated? We can start treatment with artificial tears, which will help lubricate and moisten the surface of your eye. If symptoms persist, we can explore the use of steroids. Aside from that, you would also benefit from limiting your screen time. I understand that you need to use the computer for hours for work, so I want you to follow the 20-20-20 rule. When you're working, every 20 minutes look away from your screen, that can be your laptop, your phone, or even the TV, and then focus on an object 20 feet away, and look at it for at least 20 seconds, again every 20 minutes, 20 feet away for 20 seconds. 20-20-20. Okay, Doc, so if I follow that 20-20-20 rule, does that mean I won't be getting dry eyes anymore? That rule will lower your chances of getting dry eye again. However, aging and other systemic diseases like diabetes are also risk factors. While we cannot prevent aging, keeping a healthy lifestyle through diet and exercise can help further lower your risks for dry eyes. Oh, okay, Doc. But just in case my eyes don't feel better, are there any symptoms I should be wary of? Yep, if you feel any worsening in the burning sensation in your eyes, if there is an increase in eye discharge, if there are any changes to your vision, or if you see any signs of infection on your eyes like redness and pain, please come see me again.
see things differently, we need to see them together. For decades, we've discovered connections, relationships, solutions, defining where we are now, but realizing what could be. Our achievements, fulfilling unmet needs in eye care, are made possible through listening, learning, and working with you. We continually push the boundaries of science and technology, redefining what it means to live with an eye disease. The work you do drives the work we do. Together, we advance medical education, build global charity initiatives, provide sustainable and life-enhancing eye care, driving the future far beyond just medication. In an ever-changing world, under the most challenging circumstances, we remain steadfast in our commitment to realizing the potential of our pipeline. The power of our partnerships promises to deliver even more. We can't see what lies ahead, but we know that the global burden of visual impairment is on the rise, making our commitment to easing the pressure on you so important. With our growing number of approved, longer-acting treatments, producing reliable and predictable outcomes, we're dedicated to improving the future of eye care. We're looking to you and to the young talents that will become the ophthalmology leaders of tomorrow. Because in order to see things differently, we need to see them together.
What do you call beauty? Is it our personality and who we are? Is that beauty? Or is it the thoughts and the things that we say? Is it okay to call that beauty? Is it being the same or is it being original? Beauty runs deep. It's who we are inside, regardless of age or race, regardless of hair color, tattoos, piercings, or weight. So remember, there's more to beauty than what we see. Beauty is the kindness and the love. Anyone can be beautiful.
Meet Ai. Ai has been working from home for over a year now. She spends hours and hours on her computer working, and to unwind, she often watches her favorite movies. For a while now, she's been experiencing some grittiness, burning, and some dryness on her eye. She notices that she can't stand being in front of her laptop because of the worsening of the symptoms over the day. Aside from this, her eyes were becoming red. She decides to go to her ophthalmologist for answers. By what you're feeling and how your eye is looking and your conditions at work, it looks like you have dry eye. Dry eye, or more specifically for you, keratoconjunctivitis sicca, is a problem of the tear film where there is inadequate production of or an instability of the tear film. The tear film is composed of 3 layers which are secreted by different glands in the eye. Each layer holds an important function to keep the tear film intact. Any abnormality with these can result in dry eye syndrome, as what you're experiencing now. I see, Doc. How is it treated? We can start treatment with artificial tears, which will help lubricate and moisten the surface of your eye. If symptoms persist, we can explore the use of steroids. Aside from that, you would also benefit from limiting your screen time. I understand that you need to use the computer for hours for work, so I want you to follow the 20-20-20 rule. When you're working, every 20 minutes look away from your screen, that can be your laptop, your phone, or even the TV, and then focus on an object 20 feet away, and look at it for at least 20 seconds, again every 20 minutes, 20 feet away for 20 seconds. 20-20-20. Okay, Doc, so if I follow that 20-20-20 rule, does that mean I won't be getting dry eyes anymore? That rule will lower your chances of getting dry eye again. However, aging and other systemic diseases like diabetes are also risk factors. While we cannot prevent aging, keeping a healthy lifestyle through diet and exercise can help further lower your risks for dry eyes. Oh, okay, Doc. But just in case my eyes don't feel better, are there any symptoms I should be wary of? Yep, if you feel any worsening in the burning sensation in your eyes, if there is an increase in eye discharge, if there are any changes to your vision, or if you see any signs of infection on your eyes like redness and pain, please come see me again.
To see things differently, we need to see them together. For decades, we've discovered connections, relationships, solutions, defining where we are now, but realizing what could be. Our achievements, fulfilling unmet needs in eye care, are made possible through listening, learning, and working with you. We continually push the boundaries of science and technology, redefining what it means to live with an eye disease. The work you do drives the work we do. Together, we advance medical education, build global charity initiatives, provide sustainable and life-enhancing eye care, driving the future far beyond just medication. In an ever-changing world, under the most challenging circumstances, we remain steadfast in our commitment to realizing the potential of our pipeline. The power of our partnerships promises to deliver even more. We can't see what lies ahead, but we know that the global burden of visual impairment is on the rise, making our commitment to easing the pressure on you so important. With our growing number of approved, longer-acting treatments, producing reliable and predictable outcomes, we're dedicated to improving the future of eye care. We're looking to you and to the young talents that will become the ophthalmology leaders of tomorrow. Because in order to see things differently, we need to see them together.
everyone. Welcome to another episode of EyeTV. I'm Debbie Shapna, and joining us today is my co host, Dr. Regina Valencia.
Hi, Doc Debbie. Good afternoon to all our viewers. We would like to welcome all of you to another look at the lid.
That's true, Reg. Today, we will look at the lids not only from the perspective of an ophthalmologist, but also from the point of view of our friends from dermatology.
Yes, indeed, Doc Debbie. ITV has definitely gone beyond its borders in another exciting collaboration. Derma meets Ophtha. Welcome to our ITV episode entitled Aesthetics Management for Lid and Periorbital Cosmesis.
Without further ado, let's start this program by listening to a few words from our sponsor for today, Allergan.
Thank you very much. I would like to thank TMC EyeTV, headed by Chairman Dr. Victor Caparas, for having us. Many thanks also to Dr. Gio Alejo and Dr. Denise Granada for helping us organize the event. And thank you everyone for spending your time with us. Allergan and every company is always committed to medical education. And being a patient-centric company, we always try to continue to support activities, especially non-commercial activities like this. And the success of TMC ITV has already transformed a lot of patient lives. And we as a company remain committed to add value to you and partner with you in this transformation. Again, not all patients are the same. The better we share best practices from our diverse experiences, the better we can tailor fit treatment. And this holistic management would lead to improved treatment outcomes and ultimately transform their lives. And we hope to remain as a strong partner with you in this endeavor. On behalf of Allergan and AbbVie Company, with Jaisal, our product specialist, Mike, our sales manager, and from the marketing department, Alan and Brian, this is Egbert thanking you all. Let us all transform patients' lives together. See you all again next time. Good evening.
Thank you very much, Mr. Huson. For today's episode, we will be taking all our viewers on a journey of the lid and everything that has to do with its aesthetics. First, we will explore how the lid is beautified, rejuvenated, and enhanced by our friends from dermatology. This is an interesting topic since we will be getting a lot of ideas on how dermatologists manage different cases.
Secondly, we'll also be looking through the lens of our oculoplastic surgeons in approaching periorbital aesthetics. Various surgical techniques will be discussed, with special attention to fat transposition and laser surgery.
Finally, we will see the effects of thyroid eye surgery in some patients who experience the symptoms of this condition. This highlights the fact that aesthetic surgery can truly be life changing for the better. Allow me to introduce our first speaker, Dr. Chrissy Dim Hamora. Dr. Hamora graduated medicine at the University of the Philippines and finished her dermatology residency at Skin and Cancer Foundation Incorporated, where she served as chief resident. She finished her dermatology fellowship at the Parkland Hospital and Veterans Administration Hospital, Dallas, Texas, and she also completed an ACGME accredited fellowship in Mohs micrographic surgery and procedural dermatology at the University of Texas Southwestern Medical Center, making her the first Philippine member of the American College of Mohs Surgery. Currently, she is the Deputy Director for Aesthetics by the Medical City, Section Head of the Skin Cancer Unit at TMC, and President of the Philippine Academy of Cutaneous Surgery.
Most of you here are not new to this learning platform, but if you are, you may check our previous episodes here in our channel. But for now, let's all direct our attention to our first speaker, Dr. Hamora. As always, if you have any questions, drop it in our chat box and kindly wait till the end of the episode for them to be answered. Dr. Chrissy?
Hello, everyone. Thank you very much for this kind invitation. I'd like to thank the organizers for inviting me to today's episode. So I'll be talking about the dermatologic approach to periorbital rejuvenation. I have no financial disclosures. So this will be the outline of today's lecture. How do we assess our patient? Because all patients are different. The following are the steps that we usually do when we do periorbital rejuvenation. So we need to talk about skincare, botulinum toxin injection, soft tissue fillers, the use of lasers and energy-based devices. So age is just a number. If you compare this photograph of a woman from the 1900s to Sarah Blakely, who's the same age at 50 years old, you can definitely say that 50-year-old women and men look way much younger today. The reason for that is that there are a lot of advances in injectables as well as skincare that can actually aid this. So when we talk about patient skin, we have to walk them through a journey. So it usually starts with adequate skincare, and then we can talk to them about chemical peels, as well as devices, and then neurotoxin, fillers, and lasers. So all of these occur at different depths of the skin. Okay, so how do we do clinical assessment? So assessment of our patient begins with defining the facial features because each patient is different. If you compare an Asian to a Caucasian patient, you'll notice a lot of differences. Assessment should include consideration of patient expectations, skin quality, the degree of laxity at motion and at rest, what kind of treatment can be done. So this is our game plan, as well as the budget of our patient. And finally, can I give this patient what he or she wants with the current state of her face and wrinkles? So luckily for us, because there are a lot of advances in facial skincare, we look at what's in the literature. So they found out that we can actually grade facial wrinkles so that we can give the adequate treatment plan for our patient. For example, if the folds is the problem, then most likely the location of the issue is muscular. So this will be at the nasolabial folds, the next and the eyelids. There will be loss of tone and gravity. So the optimal treatment here can be surgical, which is rhytidectomy or blepharoplasty. And you can talk about your ultrasound devices, which is deeper. However, if there are furrows on the patient's skin, then it's musculocutaneous. So you're talking about the forehead, the smile lines, and this is the result of repeated facial expression. So smiling, etc. So you can offer your patient filler substances, injectables, and implants. Next, if it's wrinkles because of cutaneous changes, which occur around the cheeks, the cigarette lines here, around the mouth, also the crow's feet, then you talk about intrinsic aging and photoaging. So for these patients, you can offer resurfacing, laser, and chemical peel. But most of the time, there's no just one treatment for a patient. You have to have a combined approach. And how do we assess our patients? So looking at this periocular photographs, you can see that there is a grading for glabellar frown lines. So Glabellar frown lines result from frequent frowning, and the periorbital lines and nasolabial folds result from smiling. So eventually, as we age, these lines and wrinkles on our glabellar areas become more permanent. So therefore, we can offer, if it's already permanent, muscle resection for our patients and also blepharoplasty. However, if it's still not permanent, you can offer botulinum toxin and injectable skin filler materials. Okay, what about the periorbital lines? You know, when you smile, you have those smiles on the sides of your face. Those are what we call the crow's feet. They can be temporary or they can be permanent. So the way to gauge this is when your patient comes in, don't let them know that you're already observing. So you actually have to look at how the skin lines change with animation, because that is actually the accurate way of seeing our patient. So periorbital lines or crow's feet are the result of overlapping skin caused by genetic laxity or intrinsic aging, the loss of tone, bone atrophy, gravity, and consequent sagging. So again, then we can offer the different treatment options depending on how our patient is. So if it's 0 to 1, so as you can see here, if it's 0, 1, 2, and 3, you can still do botulinum toxin, laser treatments, and also soft tissue fillers. But you have some patients where there is already an accompanying lidosis, such as number 4 and number 5. And really, those kinds of patients will benefit more from the surgical treatment. Okay, what about the forehead? So as you know, the periorbital area also includes the forehead. So augmentation of the bony skeleton by deep soft tissue fillers, implants, bone grafts, and skeletal osteotomies may also be necessary to treat these folds on those areas. So again, combination treatment. So for example, if the folds are only 0 to 2, then you can still do toxins, fillers, resurfacing, laser treatments. However, if you have patients who are in this one, number 4, number 5, where they're really more permanent, then you can offer more surgical options. Okay. So, of course, during our skin assessment of our patient, it's better if we have a game plan so that we can give them the proper advice and the budget so that they can actually, because, unfortunately, not all patients have, the very deep pocket. So you have to tell them, okay, this is our plan. We can work on this at this time and then maybe do it over 6 months. So that way it's not too heavy for them. So you can offer a deferred payment plan, or maybe even if you have a credit card, then you can do a layaway. Okay. So the next most important thing when you're talking about periorbital rejuvenation is actually preparing the skin around that area. Because if you have good skincare, then the skin will be more receptive to treatment. So if you can akin this to like when you have a garden, if you don't put fertilizer or water the plants, then it's harder to have a lush garden. So definitely these kinds of skincare will be helpful. So how do we start the patient journey? So first, talk to them about what causes aging. So there's intrinsic and extrinsic aging. So intrinsic aging is actually what your parents gave you. So, there are some people, they have bigger bones and then saggy skin, etc. However, there's also extrinsic aging. So what's this? Caused by sun exposure, also sleeping late, so picking your skin and then not applying substances which can take care of the skin. So the very first thing I talk about with patients is to really protect from the sun, because we live in a tropical country, and who doesn't like going to the beach? We can still enjoy the sun, but at the same time, be protected. So how can we do this? So wear sunscreen on the face every day, wear a hat, and then sunglasses. So usually nowadays, patients still ask, Doc, pero I'm in front of the camera the entire day because I'm working from home. Well, did you know that you can actually get pigmentation from the light from your ring light? Because those are lights that can also cause pigmentation. So use at least an SPF 30 sunscreen. And then also, there's no more thing now as like, oh, I am a guy, I don't want to use skincare. Whether you're a guy or a girl, you have to take care of your skin so that when you're 50 or you're 60, you'll still look like you're 30 or you're 40. So you can do this by encouraging the use of daily sunscreen, a topical retinoid every other night, and then a topical antioxidant every day. So they found out that supplementing the routine skincare regimen with alpha hydroxy acids, growth factors, and defensins can actually help. And I'll talk about more of these later. So a lot of the things that we've been discovering about the skin is we can derive it from nature. There are substances like resveratrol, which actually comes from grapes, blueberries, etc., which is antioxidant effects on the skin. So combining this with retinol 0.5% with vitamin B3 and hexylresorcinol actually has been found to decrease the signs of aging. So the use of this skin brightening or anti-aging cosmeceutical was found to provide statistically significant improvements in all efficacy endpoints. So what are we talking about? We're talking about aging skin, such as fine lines, sallowness, which is like, yellowish pigmentation on the skin, the lack of clarity and wrinkling. So when you talk about what's uso now is like Korean skin. So we're talking about these kinds of products. Aside from that, we can talk about a niacinamide, 4.4%, again, resveratrol, and then hexylresorcinol. So these have been found to, as little as 2 weeks after starting the products, you can have reduction in fine lines, and actually you have more radiance and smoothness that is statistically significant. And by week 4, imagine in just 1 month of using these products, you can decrease hyperpigmentation, increase overall skin clarity, and evenness of skin tone. So again, it's never too late to start a skin regimen. So aside from this, what else can we do? So I teach patients to look at the back of the ingredients of their products so that they can, it doesn't actually have to be expensive. You just have to read the label. So the other thing that you can look for is 30% vitamin C. So they found out that this one, together with vitamin E or alpha tocopherol acetate and ubiquinone, which is coenzyme Q10, in this 12-week open-label single-center study, they found that it actually decreases hyperpigmentation and photo damage in clinical grading scores for all parameters assessed at weeks 8 and 12. So again, it shows clinical improvement and efficacy. So another thing that you'll probably see online is hyaluronic acid. So hyaluronic acid is actually present in our bodies. And as we age, we actually tend to break this down faster. But it can actually improve cell differentiation, wound healing, and decrease inflammation. So this is also something that you should look as an ingredient in the products. So again, let's talk about vitamin B3. Topical niacinamide has been shown to provide significant improvements in fine lines, wrinkles, and decrease hyperpigmentation spots, improve texture, and decrease red blotchiness. Okay, so aside from skincare, so you've already started skincare, what are the things that you can do in the clinic? So you can start usually with something that has no downtime, which is botulinum toxin injection. So how does botulinum toxin injection work? So actually, upon injection into the muscle, botulinum toxin A inhibits the release of acetylcholine at the motor end plate. So it produces a functional denervation. However, as you know, the goal now is actually not to freeze the patient's face. You still want to have dynamic facial movement. You don't want to look frozen because that looks so artificial. And like for us, that's so 80s and 90s. And in our current century, we want to have dynamic facial expression, etc. So the approach now is not to cookie cutter each part of the face. You actually have to do a pan-facial diagnostic approach. So for example, the original paradigm was just to relax the upper face, fill the mid face so you had those chipmunk cheeks, and then relax and fill the lower face. Actually, with the latest trends in the beauty and dermatologic industry, we have to assess our patient appropriately and understand the etiology again of the facial wrinkles so that we can have more equal use of toxin and fillers in all facial zones. So the goal now is to use less fillers and less toxins, but to produce a more natural result. So muscles are targeted when their excessive contraction is the primary cause of the changes, and volume is restored where there is a primary cause. So again, the patient-tailored approach is very important. So although the original objective of botulinum toxin and treatment was to paralyze target muscles, current understanding is that most desirable outcome is modulation. So meaning decrease or attenuate the muscular activity, but still allow your patient to have facial expression. So aside from this, so as I mentioned earlier, you have to observe your patient as soon as they come in to do both the static and dynamic observation. Sometimes I have patients who just send me a photo, Doc, what can you do for me? It's still not the same. Actually, I tell them, can you send a video of you talking to someone? So that way you can see how the face is moving. So you can more or less compute where you can put the Botox and then where you can put the filler. So the real image of a patient is obtained through observation of spontaneous animation rather than animation on command. So that gives you a more natural appearance. At the same time, you don't want the filler to look like it's stuck in one place. So you don't overfill just one area. You want the filler around the patient's face so that it can give more support in the surrounding facial areas. So these are the global aesthetics consensus when it comes to botulinum toxin A injection. So now we're talking about for younger patients, it's all about tweaking. So because we don't want to look old faster, so the objective is to prevent rhytids in most young patients. And it's critical to not overuse botulinum toxin, to just use very little amounts so that the patient can still move their face. However, for older patients, you have more considerations. So decreased elasticity, loss of volume, deflation of soft tissues, decreased underlying bone. So actually, they found out that a lot of the need for support comes from the deeper portions of our face because the bone is getting smaller. So that's why we need more deeper facial fillers. So combining botulinum toxin together with fillers is the mainstay of current treatment. And these are actually the recommended expert panel opinions on how much to use on the upper face. So again, for the glabellar frown lines, it's usually 2 to 4 units per area on the glabellar area. For horizontal forehead lines, also 2 to 4 units spread on the forehead. And then you have your lateral canthal lines. You can use 1 to 4 to 6, depending on how many lines they have on the crow's feet. And then for brow elevation, the way to do that is actually to inject a little bit at the tip of the eyebrow, so it will lift it up. So you can use about 1 to 2 units per side. So for lateral canthal lines, actually, I just made this example. So for example, you have this patient. How do you mix the toxin and the filler? So you can see here that she has a number 11. So you can inject at the procerus and then the corrugator about 2 to 4 units per area, depending on the facial movement. And then you can see here she has a horizontal forehead line. So again, you can inject about 2 units there. And then also for the crow's feet, you can use 2 units per line on that area. However, you need to support the face with filler so that you can actually make the effect longer lasting, because even if you just inject botulinum toxin but there's no support from underneath, then you actually have less of an effect. Okay, so just to be aware, you have to tell your patients, although you don't have to discuss in detail, that these are the most common adverse effects of aesthetic use of botulinum toxin A. So you can have asymmetry, ptosis of the eyebrow or eyelid, or unmasking of compensated eyelid ptosis, impairment of eyelid function, lower lid retraction, lip ptosis, and atrophy. So therefore, it's very important to assess your patient before doing any kind of treatment, because you don't want to make it worse. So as in medicine, primum non nocere. So these are the global aesthetics consensus group recommendations. So an individualized integrated approach to assessment and treatment planning, selection of botulinum toxin as primary treatment only if the target muscle is the primary etiology of facial disharmony, analysis of target muscles in the context of adjacent muscles and associated soft and hard tissue. So lower doses for the upper face and some regions of the lower face. Again, intracutaneous injection were indicated to limit the depth and magnitude of effects, and more frequent combination of toxin with fillers for all facial regions, including the upper face. So let's talk about soft tissue fillers. So soft tissue fillers work in harmony with botulinum toxin injections, skincare, as well as laser and energy-based devices. The purpose of this is that, as I mentioned earlier, soft tissue fillers actually work at the level of where the deflation is. So it can be used to fill temple depressions, erase crow's feet, also restore volume to the cheeks if there's decreased volume there. It can also soften, like marine lines around the mouth, and add definition to the chin and jaw line. Okay. So the most popular soft tissue fillers in our country is hyaluronic acid. So the soft tissue fillers are again differentiated based on particle size and G prime. So usually if it has a higher G prime, then it's injected deeper for volume and support. And if it's injected more superficially, then it should have a smaller particle size. So usually the smaller particle size fillers will absorb more water and result in hydration and glow. So the other kinds of fillers that we have in the Philippines are poly-L-lactic acid, calcium hydroxyapatite, and of course, autologous fat, or rather calcium hydroxyapatite. Okay. So when we talk about soft tissue fillers, we have to talk about our anatomy. So usually if it's anterior to the line of ligaments, then that you're looking more for a volumizing effect. But if you're looking to really lift the patient's face, then you have to inject the fillers posterior to this line of ligament. So you're talking about your mandibular ligament, zygomatic cutaneous ligament, and your superior temporal septum and your orbicularis retaining ligament. So basically, that's where you do your support. Okay. So I just like to share this video of how to do fillers for the tear trough. So again, I've already assessed this particular patient. She's actually just in her 20s, but as you can notice, she does have a visible tear trough on both lower eyelids. And what you can also see here is she also has very visible veins on the lower eyelid. So I'm marking the area and telling her where she needs the improvement. But at the same time, we also have to mark the areas because, of course, we have to be aware that the most dreaded complications of fillers is vascular necrosis. So how do we avoid that? We have to avoid injecting into the blood vessels, the veins and the arteries on that area. So the most important thing here is we have to study our facial anatomy. So luckily for us at the Medical City, we do have a lot of anatomy courses. So avail of that, especially for the residents. And as you can see here, I'm injecting, and actually I'm going to inject on the temple because this is an area where it's relatively less vascular. So you can put a bigger depot on that indentation on the temple. And with just that injection around the periocular area, you can actually lift the eyes already. So soft tissue fillers are better for people who are not yet ready to have like surgical blepharoplasty, etc. So it's a step approach. So I think if Dr. Ali can agree, usually a dermatologist will offer dermatologic treatments first. And then when the patient is ready, then they can have the surgical approach offered already. So they're not afraid to do the procedure. So as you can see here, actually here I'm using a small particle filler. So that's why I can inject directly on the tear trough. It's not going to produce a sausage shaped deformity. So usually for the tear trough, you have to be worried for like the Tyndall effect. You know, Tyndall effect is that bluish discoloration when you can see the filler, because the filler is actually white, but if you can see it under the skin, then it's bluish. So you have to use a smaller particle filler. And what's important there is to always massage the filler so that it can blend in with the rest of the skin. Again, what I'm doing here is I'm injecting slowly uh, via the depot, and actually you have to withdraw your needle so that you can see if you're into any blood vessel, whether artery or vein. It's very important to do it slowly so that you don't push too much force on that area. So again, this patient has already been given topical lidocaine, so that's why she's not flinching. So patients tend to come back if they have a relatively painless kind of procedure. So make sure that your patient is comfortable, and then maybe offer music and then talk to them, so that way they will be comfortable and relaxed during the procedure. So I'm also injecting here at the top of the eyebrow, because that way it can lift it up. So I'm injecting around the blood vessel, around it, so that you can see that I'm avoiding the blood vessel. And you can see here, there's a decrease in the tear trough area already. So this patient was quite happy. Of course, the red marks will disappear in a few days, usually about 3 or 4 days. And then they can do their skincare, etc. Okay. So let's talk about how do we use it in real life. So I'll talk about some patients. So please try and don't take any photographs here. So combination skincare with botulinum toxin and fillers. So for this particular patient, she's actually in her late 50s, and she didn't want that sausage underneath the lower eyelid. So combining skincare with botulinum toxin and fillers can give you a fresher appearance, and also reduces the sausages on the lower eyelids, and it can also lift the upper eyelid. So you can see here, there is actually less eyelid ptosis. This is the pre-treatment, and this is the post-treatment. You can see she has a bigger area to put her eyeliner. So that's just with, I put soft tissue fillers on the lateral eyebrow, as well as her temples. And of course, the first step in doing soft tissue fillers is really augmenting the mid face. So that way you'll have more support. And then I used a toxin on her glabellar area, and also her horizontal forehead lines. So sometimes we get young patients who really want improvement. So again, they want the happy eyes effect. So that seems to be in right now because of the Korean trend. So with this particular patient, you can see that with skincare, botulinum toxin, and fillers, you can have already a reduction in the fine lines underneath the eyelids, and actually decreased asymmetry. So you can notice here, her left eyebrow is actually higher than her right. She pointed that out to me. Doc, my left eyebrow is higher. So I told her, okay, we can try to decrease that by injecting toxins. And you can see here, it's actually more even now after the treatment. It's a little bit lower now. So producing more facial asymmetry actually gives the patient more beauty. So that's been found in studies. So for our older patients, we have to tell them that, these treatments don't replace surgery. So that's the first thing I tell them. But it can be a step down or step up. So from treatments to surgery, etc. So depending on how prepared they are, but it can give you a fresh, relaxed look. So again, for this patient, this is pre-procedure. You can see 2 weeks after the procedure, there's decrease in the glabellar folds, and also the lines on her upper eyelids. So that's using botulinum toxin and filler. So again, here, before and after, there's a more natural and fresh look. There's reduced crow's feet. And also you can see here, the nasalis lines are also decreased. So it doesn't look fake. It looks quite natural. And sometimes you have that male patient, they want to look better, but it's not halata. So that's when we can offer these kinds of treatments. So this patient had botulinum toxin and fillers. So you can see here, there's reduction in the forehead and glabellar lines, and also reduced crow's feet. You can see here on the lateral aspect, it's reduced, and then lifting of the upper eyelid. So there's also reduction in the lines of the lower eyelids. Actually, for this patient, I think at the time we didn't have the laser yet, but you can actually offer laser treatments for the lower eyelids to tighten the skin on that area. Okay, so how do lasers and energy-based devices work? So lasers actually come through a spectrum of light. So you have your more superficial lasers, which affect the epidermis, and then you have your deeper lasers, which affect the dermis. So radio frequency is a kind of technology which affects the deeper portions of the dermis. And then lastly, you have your microfocus ultrasound. So the microfocus ultrasound can actually affect the tissues deeper. So you have your 1.5 millimeter, 3 millimeters, and 4.5 millimeters. So this can be used in adjunct to surgical facelift or blepharoplasty. So again, I don't have any financial disclosure here, just to show you. So lasers usually affect the top portion of the skin, so we can use that to vaporize the superficial skin. This can be precise and fractional. For radio frequency, it's actually a bulk heating. But for microfocus ultrasound, this is actually directed to the level of the device. So that's why you have your 1.5 millimeter, your 3 millimeter tips. So that way you can go deeper into the fat and connective tissue as well as your SMAS. Okay, so what laser machines can help with collagen remodeling? So you have to know that there are two types of lasers. You have your non-ablative and your ablative lasers. So the non-ablative lasers produce less to limited downtime, but your ablative lasers will have more downtime. So your non-ablative, you have your 1064 Nd:YAG, your pulse dye laser, and then your Q-switch 1064 532 Nd:YAG. And then for your ablative lasers, you have your CO2 laser, carbon dioxide laser, and your erbium YAG laser. So this can either be fractionated, meaning in different columns, or you have your single beam, which is a single streak on that area. So how do we prevent post-blepharoplasty scar? So as you know, in Filipino skin, we tend to form pigmentation and scars because we actually have more inflammation. So what we can do is to use a laser that will decrease inflammation and neovascularization. So at the Aesthetics by the Medical City for telangiectatic scar and macular erythema on post-blepharoplasty areas, we have what we call the pulse dye laser. So this is done every 2 to 4 weeks, and what it does is it seals the blood vessels that feed the scar. So when you have less blood vessels on the scar, you have less pigmentation also. So that way you don't have a brown line on that area. So this is what we call a laser scar revision. So treatment can begin after suture removal, and actually vascular scars respond earlier when it's redder. So it's better to do the laser as soon as the sutures are removed as possible, so that way it won't be white, because if it's already white and thick, it will be hard to treat. You have to treat the vascular component or the red component of the scar. So just to show you, this is using dermoscopy. It's like a little handheld microscope that we can check the skin. So this is my patient that I did excision here. And you can actually see the blood vessels starting on that area. That's what you want to treat with the pulse dye laser. You want to prevent those little telangiectasia so that you don't get a dark scar and hyperpigmentation. And then you decrease also your keloid formation. Also, at Aesthetics by the Medical City, at our derma laser, we actually have the Star Walker, which is a very advanced Q-switch laser system. So this actually does wonders for brightening the entire face. and for tightening and lifting the periorbital area. So we can talk about like this particular patient. She had a lot of blotchiness on her skin, and she had this treatment, and you can see the reduction in the blotchiness. And we can also treat the panda eyes using this one, you know, when you have those dark circles around the eyes. So next we talk about energy-based devices. So again, I talked about this earlier. You have your infrared technology, your monopolar radio frequency, your bipolar radio frequency, and your microfocused ultrasound. So microfocused ultrasound is the deepest kind of energy-based treatment that we can do for the face and facial skin. So this causes contraction at those levels of the dermis. So it's an immediate type of contraction and leads to a production of new collagen and tissue remodeling. So the net effect is actually lifting and tightening of the lax skin. So how do we do this in our practice? Because we want to know how we can make it effective. So the first thing we have to do is to manage patient expectations, because dermatologic treatments will not replace surgical treatments. That's what we have to emphasize. So from the get-go, you have to give a consent so that you can cover all the side effects and be prepared to handle any kind of adverse effects. So, and also patient education is very important to set the appropriate expectations. So you can also price by units, vials, and give flexible options so that they can actually plan their beauty journey. And then the important thing is to make no guarantees concerning duration, because some treatments like botulinum toxin can last from 3 to 5 months, but other treatments such as fillers can last from 6 months to 2 years and longer, depending on the particle size. So sometimes they will get cheaper options elsewhere, but actually they use the really small particle size fillers. So also appointment availability, and the doctor can be reached when necessary. So you have to be a call or a text away. And then of course, know when to refer for surgical management. You have to be able to tell your patient, okay, because of the degree of your ptosis on the eyelids and what you want to achieve, I think it's better if we refer you for surgical management. Okay, so again, lastly, the most important thing, because our relationship with the patient is actually that, it's a relationship. So you have to know when to manage patient disappointment. So when treatment results are not up to expectations, admit it and do something about it. So as clinicians, that's why we have a very long education, more than 15 years of education, you know, because we have to know all the different facets of patient care. And if there's something that we need to address it right away. So in conclusion, periorbital rejuvenation starts with establishing a consistent skincare regimen, taking note of key ingredients such as retinol, tretinoin, vitamin C, niacinamide, hyaluronic acid, and resveratrol. We need to assess the whole face so that we know where support is needed and what kind of treatment is necessary for the patient. Combination treatment is more effective, but budgetary constraints may affect this. So we have to live in the real world and then give the patient a treatment plan with a time schedule that will help him or her achieve his or her goals. And then knowing the advantages and limitations of the treatment options is as essential as knowing when to refer for surgery. So again, I'd like to thank everyone for your kind attention. Thank you for listening. And I hope everybody has a good weekend ahead. Thank you very much.
When you're in the zone, round 2, fight! And things start to get blurry. Soothe dry and tired eyes, and keep on winning!
Thank you very much for that comments regarding your insights on the procedures you mentioned. To all our viewers, kindly type your questions in the comment section at the side and we will try to answer them later. For now, let us have this short break and watch this video prepared for us by Allergan.
When you're in the zone, round 2, fight! And things start to get blurry. Soothe dry and tired eyes, and keep on winning!
Okay, for our next part, it is my pleasure to introduce our very own Dr. Alfonso Bengzon, a consultant at the Eye and Vision Institute of the Medical City. He graduated medicine at the University of the East, Ramon Magsaysay Memorial Medical Center, and finished his ophthalmology residency at the Makati Medical Center, where he served as chief resident. He pursued and completed his fellowship in oculoplastic, lacrimal, orbital, and reconstructive surgery at the following institutions: Edward S. Hartness Eye Institute, Columbia Presbyterian Medical Center in New York, University of Hawaii, Camera Eye Clinic, and at St. Francis Medical Center, Hawaii. He is currently an active consultant at the Medical City, American Eye Center, and the Bello Medical Group. Again, let's all welcome Dr. Ali Bengzon.
Hello. Yeah. Can you see my screen?
Yes, Dr. Bengzon, we can see your slides.
Okay. Thank you. So I'd like to thank the organizers for giving me this opportunity so soon again to share. It's always an honor and a privilege to be given this opportunity. And what an amazing lecture by Dr. Hamora. I really like working with dermatologists for aesthetics. I've been very fortunate to be to have that opportunity to work with the dermatologists for the past 15 years, and I find that they just help make my work look a lot better. So I always refer uh, a huge number of my patients to dermatologists either before surgery to help them with skincare, which Dr. Hamora said, helps the surgery in terms of healing. When you have healthy skin, your skin heals a lot better and a lot faster after surgery. And then after surgery, I refer to them for maintenance and for other adjunctive treatments, and it just makes the surgery look a whole lot better. So for this talk, I'd like to go through some of the considerations that, as an oculoplastic surgeon, I go to personally when I'm assessing patients. I'll also talk about upper lids, whether it's skin and fat, specifically volume deficit when you have deep superior sulcus. I'll show some patient examples and a surgical video, and same with the lower lids. I'll go over specifically the volume deficit. Dr. Hamora mentioned the management of tear trough um, with the fillers, uh, and surgically there's a way to also manage it, and I'll talk about that a bit later. So as with any pre-op evaluation uh, in the eyes, you have to do, of course, your complete history and eye exam. You have to do a dry eye assessment because we know that blepharoplasty can lead or worsen dry eyes that are already pre-existing. And then you move on to your eyelid assessment and talk to the patient about their goals, talk to the patient about your evaluation, and manage the expectations. And I do the same thing that Dr. Ahmar does. The moment the patient enters, even before we start talking about what their goals are, during that time you're just asking personal questions, making chica. I'm already observing how their eyelids move when they have facial expressions or when they don't have facial expressions. It's a dynamic thing. So, um, like Dr. Amar said, it has to look natural. That's your end goal: to improve, to enhance, but in a natural way. So that begins the moment they come in. Because as I've noticed, when they notice you're starting to examine them, and they think that's the time the examination begins. They start to have these subconscious movements or positions. They start to raise their eyebrows. They start to tilt their head, and that's not natural. So um, these are the considerations that goes through my head when I'm some of the considerations when planning eyelid rejuvenation surgery. I look at areas of excess and deficit. Where there excess tissue? Where are there deficits of tissue? Is the excess only skin, or is there skin and fat, or is there volume excess? Should the excision, in other words, should the excision only be skin, or should you include subcutaneous fat or deeper fat, orbital fat? How much skin should be excised safely? You don't want to overcorrect it or be too aggressive, which often leads to complications. So, how much fat should be removed, and where? Where is the fat that should be removed? And what fat should you leave alone? Is the fat in the preseptal subbrow space or the orbital fat space? Should it create a lid crease? If so, how high or low should it be? Because it has to be congruous with the entire face. What is the appropriate contour of the crease? Should you do an external or a transconjunctival approach when dealing with a lower eye bag surgery? And finally, if there's volume deficits, how should you address it? So oftentimes when I see a patient with a volume deficit like a tear trough, especially if she's young, I'll just refer the patient back to dermatologist. Most young patients who don't have any skin problems yet, and it's just the volume deficit, would be happy with just a filler, right? And as Dr. Hamora said, they might not be ready for surgery yet. So you shouldn't push them into it. You should offer them options that are more conservative. And that's how you build trust as well. Because just because you're a surgeon, you're not pushing the procedures that benefit you. You're thinking about what benefits the patient more, and that goes a long way in building trust. So I'm just showing this picture because it's a picture that shows where all the excess fat could possibly lie. You can see fat in the subbrow area. You can see fat on the lids, the orbital fat protruding. And in the lower lids, you can see all the fat pads, lateral, middle, and medial. And this is a patient who has Graves. I'm not going to talk about this because Dr. Ken Lagonzadas prepared an excellent lecture precisely on this topic. So I just wanted to show this because you can see everything in one picture. But really, this is an example of upper lid fat pads. This is the more common type of patient to come in. The upper picture shows that this lady has a larger lateral fat pad on the right eye as compared to the left. So going into the surgery, you're going to have to remove more fat on the right upper lid. The patient below, however, has practically no fat on the lateral aspect of her lid. It's relatively flat, but it's more of the medial aspect. So going in, that's where you have to concentrate your fat excision, and of course taking off some skin to improve on the contour of the eyelid crease as well. Speaking of eyelid crease, some patients will come in and they say, I want an eyelid crease. I want to look like a Caucasian. I want that high, deep set eye. And it's up to you. It's your responsibility to tell them if that's a good idea for them. So there are patients who have a lid crease, like the patient on the upper left, but the lid crease is being obscured or covered by the skin, the excess skin. So that's easy. All you need to do is remove that excess skin, and the natural lid crease comes out. There are patients like the patient in the lower left who don't have a lid crease at all. This is trickier because you have to create something that's not there. It's not just a matter of exposing it. So this is where you really need to talk about where the lid crease should be, and should it be continuous, or how long should it be? And that's a long discussion that you should have with the patient, and it should be documented as well. So another example. So for upper lid pre-ops, this lady on the top, they basically skin only. There's a lot of drooping skin. as well as the lower lid has eye bags and a lot of wrinkles and lines. Um, but it looks like it's going to be a tough surgery, but actually no, because it's just really simple skin. The lady in the middle picture is a little more challenging because aside from having more uh, skin that's in excess, she also has a volume deficit on the left upper lid, as you can see, and there's a lot of asymmetry there. So when planning for this surgery, you need to take that into account. And the lady below, she's younger, obviously, and her skin is not that loose. There's not much excess, although she has multiple lid creases. But what stands out is the volume deficit on the right upper lid. She has a deeper set or a deeper superior sulcus on the right upper lid compared to the left. So this is an example of upper left skin only excision. This is an upper and lower blepharoplasty with just skin excision. Um, and this is an example of obviously skin is not enough just to be excised here. You need to also remove some of the subbrow fat pad as well as some of the orbital fat pad in the medial aspects of the lady in the upper pictures. That's her pre-op picture, and then her post-op. That's about 2 weeks. So you notice there's still a little bit of swelling on the skin at a 2 week follow-up, but a big improvement nonetheless. No? And the patient in the lower left has no lid crease and has a very puffy upper lid. So aside from removing the excess skin and the fat, you need to create a lid crease as well. So that's a multiple procedure. And this is also a 2 week picture. So again, still a little bit puffy and swollen, but in another 2 weeks that will look really nice. Okay, let me just show you a video of. So this is we're using a CO2 or carbon dioxide laser here. We've already mapped out the amount of skin to be removed, and we've already injected the anesthesia. And as you can see, using the CO2 laser, this procedure has minimal blood loss. I start off in the medial aspect, removing just skin, depending on what the pre-op assessment dictates. But when I reach the lateral third of the lid, I start to go a little bit deeper, including that includes the orbicularis muscle. That's why you see a lot more bleeding, because you're going through the larger calibered blood vessels laterally on the lateral aspect of that upper lid. You can see a little bit of the fat protruding as we approach the orbital septum as well. Now, at this point, once you excise this, if you were just doing a skin-only excision, you could just close up that wound already at this point. But if you're doing fat excision as well, then the next step would be to dissect through the orbital septum, and I'm dissecting through the lateral aspect. As we know, the upper lid has two fat pads, the medial and middle, but the middle has a tail, a fat pad that extends laterally and over the lacrimal gland, possibly. So you have to be very careful in this area, and the structure that you need to be careful or watchful for, obviously, is the lacrimal gland. You can tell the difference. Sorry. You can tell the difference between fat and lacrimal gland. The fat is glistening and yellow, and the lacrimal gland is grayish to white, and it's dull. It doesn't have this sheen that the fat has. So at this point, we're just removing fat. If you were not using a CO2 laser, you would be clamping this fat with a hemostat clamp, excising it with your radio frequency probe or Westcott scissors, and then you'd be cauterizing. the amazing thing with the CO2 is as it's cutting, it's also cauterizing blood vessels. So you skip that whole hassle of having to use a clamp. This is the medial fat pad. You have to be very careful here. You don't want to remove too much fat because you'd be giving the patient a sunken appearance, and that would look worse. It would make them look haggard. So I'm conservative here. I only remove the fat that's prolapsing, and I don't push on the eyeball, which tends to cause more fat to prolapse, and that's when you end up excising too much fat. Okay, so for upper lid volume defects, what you call the deep superior sulcus, which in this patient is more prominent on the left upper lid, we do there are fillers. Obviously, Dr. Hamor talked about that extensively. But surgically, there are a couple of other options. There's autologous fat grafts, and there are fat transmission flaps. I don't do autologous fat grafts, but I'll talk about it, just so that you know what it is for those who are interested. It's autologous, so you get the patient's own fat from a separate surgical site. Often it's in conjunction with liposurgery or liposuction surgery, where fat is taken from the abdomen or the buttocks or the thighs, and then it's processed, centrifuge to separate the adipocytes from the blood, and then the adipocytes are then injected into the defects in the face or the deficits in the face or periocular area. It's been around for years, been done safely for years. It's kind of toxic to do. So what I usually do is fat transmission flap, and these are, this has also been around for quite a number of years. And because of the invention of fillers, not done as often as it used to be, but I still like doing it, and I'll explain why later. But before I show you a video, let's just review the lid anatomy. So the green part of this illustration is the orbital septum, and as you know, it separates the anterior lid from the orbit. No? So anterior to the orbital septum, you'll find the suborbicularis fat pad, and that's subbrow fat, in other words. And then posterior to it, that's where you have the orbital fat. Now, in the lid crease is formed when the orbital septum fuses with the levator aponeurosis levator muscle. Now, in Caucasians, this fusion occurs much higher in the levator aponeurosis, and that's why they have that deep set eye, because having that fusion occur higher keeps more of the fat back into the posterior. Where in Asian eyes, that fusion occurs much lower in the levator aponeurosis, or sometimes even in the tarsal plate, which allows fat to come forward more. Therefore, you have a fuller eyelid, and we don't normally have a deep set eye in Asians, except when they age, and the loss of fat when Asian women develop the deep sulcus is mostly lost from the fat in the subbrow area. Okay, so the suborbicular fat pad is what usually is lost, and there's still most of the time some fat behind the orbital septum. So this is our target. When we do fat transposition, what we're doing is we want to mobilize the fat behind the orbital septum and bring it forward to fill up that defect. So let's move now to the video. All right, so similar to doing the regular blep, we're using again the CO2 laser. Excising the skin and muscle flap from the upper lid. Okay. Let me just hang it again. Sorry about this. Okay, so once you've so it's basically the same as when you were going to excite the fat. in the upper blepharoplasty. But in this case, instead of excising the fat, you're just releasing it, making sure you mobilize it, uh, and then draping it over uh, septum and bringing it down towards the tarsal plate or towards the level of which you've determined you want to move the fat pads. So this is just using the CO2 to open up the orbital septum and use some blunt dissection to tease out the fat and sort of drape it over the area. This is an important step. You need to make sure that the fat pad is well mobilized. You don't want it to be stretched out and taut because that compromises the blood supply. So at this point, I'm going to apply 3 sutures that will hold this fat in place in the location that I want it. Then depending on where you want to locate the fat, you can either suture it to the tarsal plate if you want it really low, or you suture it higher up in the septum or in the orbicularis layer. Okay. So this is the middle suture, and then the medial suture. Now, before I close, because at this point you can close this already, but before I close, I want to make sure that I'm satisfied with how the fat is, where it's located, and what it looks like in a dynamic way. And this is why I like patients to be under local anesthesia. I don't really normally put them under sedation or general anesthesia because in the middle of the surgery, I will want them to open their eyes and blink and show me if that's okay, right? So I'm satisfied with that. Then I just proceed and close the wound with a Prolene 6.0 with a continuous suture. So you can skip this part and let's proceed. So these are examples of those patients that had that fat transposition, again, at about 3 to 4 weeks post-op. And it looks natural, and I think the defects have filled out quite nicely. Right. So how about the lower lid? And here we go. Here's the tear trough. And these patients are young, and yes, we could actually, they were actually given the option to use fillers, but for their own reasons, given the option and discussed with them all the pros and cons and advantages of each of these options, they decided to choose the surgical option. So before we show the video, it's important to know just the anatomy and the landmarks of what you're doing or where you're going to dissect. So when you're dissecting to the tear trough area, the most important landmark that you need to know is the levator superioris alicinasi. So it's that muscle more medial and inferior to the orbicularis. And that's the landmark that tells you to stop. That's when you see that, that's as far as you should go. That's usually where the defect is going to be. Be sure, you usually mark the defect preoperatively. So let's start this video. And we're using an external approach here. So again, using the CO2, just dissecting through the skin orbicularis all the way down to the orbital septum and tarsal complex. That's the plane you need to find. So right after the orbicularis is the septum, and that's the plane you need to dissect through. So right at this point, I am at that plane, and I will use the CO2 and blunt dissection to dissect medially, more posteriorly. So at this point, I'm looking for the periosteum, which will appear white, and inferior to that would be that levator superioris alicinasi. And once you identify that, there's the periosteum right there, and that's where I'll stop. And it coincides with the area that I marked preoperatively. So at this point, I'm able now to start mobilizing the fat again. This is the medial fat pad, going through the connective tissue that separates the fat from the lateral fat pad. So I'm teasing it and pushing it inferiorly, just to make sure that it's easily and freely mobilized. So at this point, I usually stop and compare, and I want to check if I'm happy with the amount of fat that I've brought down to the tear trough. And you can see in the left eye still hollow, but the right eye has kind of filled up already. So at this point, since I'm satisfied with that, I proceed to suture the medial fat pad to that periosteal area superior to that muscle, the landmark. Okay. So as you tighten the suture, you see that fat pad like move downward and just fill up that space like that. And then I do the same with the middle fat pad, just suturing it into that space. Okay, so I think we can probably forward this. Okay. So these are the pictures above are their pre-op photos, and the pictures below them are their post-op photos. As you can see, those tear troughs have been filled up quite nicely. So there are people who aren't fond of fat transposition, and the reasons they give are it can lead to lumpy eyelids. But I feel that this happens when the skin on the lower lid is too thin. So in those cases, I probably won't do it. Or if surgically during the procedure you place the fat pad anterior to the orbicularis, which you shouldn't do if you were in the correct surgical plane, and that those two conditions could lead to lumpy eyelids. They also notice some patients have prolonged swelling, and the reason for that, as I mentioned, is if you don't mobilize the fat well enough and there's too much stretching and tension, this causes a faulty blood supply and compromises drainage as well. And that's why there's longer swelling and don't heal as quickly. And the third argument is you can't reverse the effects as easily as you could with a filler. And that's true. But if in a way that for me, that's not necessarily a bad thing. I mean, if you did the surgery correctly and it looks good, then you want to make it last long as it can, right? But it's true that when you use fillers and you don't like the way it looks, there are ways to reverse the effect of the fillers, and you can't do that with this procedure unless you go in and do a reoperation to make adjustments. But why do I like doing it? Well, because it can address large volume deficits. It might not address completely, but definitely there will be a big improvement. And whatever deficits are left, you can augment that with fillers as well. But at least you won't have to use as much fillers. As what Dr. Hamura said, the less you use, the better, because it looks more natural. The second thing is it has its own blood supply, so it lasts longer than fat grafts or the fillers. You can see the effects relatively quickly, earlier at least than fat grafts, because fat grafts have post-operative fat regression. Up to about 30 to 50% of the fat that's injected will be lost. It's a simpler procedure because you don't need to do an additional liposuction. There's faster recovery, less downtime. And Although very rare, there has been documentation that fillers led to blindness by forming an embolus. So, in conclusion, I just want to make a couple of points. One is don't forget your complete ocular history in PE. Do a thorough assessment. Look at excess deficits. Look at location, extent of tissue to be removed, and plan for having a congruous facial look. You have to align and clearly outline your surgical goals and expectations with your patients, goals and expectations. And you need to document this discussion with your patient, because a funny thing is sometimes patients forget what you discussed with them before. After the surgery, they don't really remember. So with that, I thank you all for your patience, and thank you again for inviting me.
Thank you, Dr. Bengzon, for the enlightening presentation. It's always fascinating to watch your bloodless blepharoplasty with the CO2 laser. And it's also helpful to review these topics as we tackle them in real practice. So again, for our audience, please do not hesitate to ask your questions by typing in the comment section below. Our last speaker is Dr. Ken Lagunzad. He graduated medicine at the University of the East Ramon Magsaysay Memorial Medical Center and finished his ophthalmology residency at the Philippine General Hospital. Dr. Lagunzad then finished his fellowship in ophthalmic plastic reconstructive, orbital and lacrimal surgery at University of Hawaii, John A. Burns School of Medicine. He is currently a clinical associate professor at the UP College of Medicine, consultant at the Department of Ophthalmology and Visual Sciences at PGH, an active consultant at Legazpi Eye Center in Albay, and he's also the head of the plastic and lacrimal section of the TMC EBI. So Dr. Lagunzad, the floor is yours.
Good evening, everyone. I'd like to thank the TMC EVI for inviting me for tonight's talk. I'd like to thank also Dr. Hamora and Dr. Bengzon for their excellent lectures. I really learned a lot. So tonight I'm going to be talking about the aesthetic rehabilitation of thyroid eye disease. Thyroid eye disease is an autoimmune disease that can result in visual impairment and cosmetic disfigurement that can significantly impair a patient's quality of life. Ophthalmic findings include diplopia, dry eye, and optic neuropathy. Soft tissue changes include proptosis, eyelid retraction, periorbital fat expansion, and edema. Medical management and pharmacotherapy have generally been reserved for the active phase in an attempt to stop inflammation. However, for many decades, there has been a limited success to reverse or modify the disease course and the disease endpoints, such as proptosis, diplopia, and lid retraction. Elective surgical management is classically reserved for the inactive phase and is generally a multi-stage approach. Tonight, I'll be sharing my experience on the aesthetic rehabilitation of thyroid eye disease. This is the outline of my talk. So first, I'm going to talk about a little bit of a background on thyroid eye disease for our listeners. And I will discuss the diagnostic criteria for thyroid eye disease. I will also discuss the clinical activity evaluation. For that is very important, and when to approach the management for it, whether it's medical or surgical. And I will be talking about a specific case focused on the evaluation and the aesthetic rehabilitation of thyroid eye disease. And I will give my conclusions and recommendations. So, thyroid eye disease and Graves' disease are both autoimmune disease disorders. However, many people think that Graves' disease and thyroid eye disease are the same because people often have both diseases at the same time. Up to one half of people with Graves' disease develop thyroid eye disease. And in Graves' disease, your thyroid is affected. When your thyroid eye disease affects in your thyroid eye disease, it affects your muscle and fat behind your eyes. But they are separate conditions that require different treatments. However, it is of utmost importance that we determine if both diseases occur at the same time so we can work with our endocrinologist friends to take care of our patients. There are other names of thyroid eye disease that are known, and these are the following: Graves' eye disease, Graves' ophthalmopathy, Graves' orbitopathy, Graves' disease eyes, thyroid-associated orbitopathy, and thyroid ophthalmopathy. To discuss the pathophysiology of thyroid eye disease, in simplest terms, the underlying pathophysiology of thyroid eye disease is thought to be an antibody-mediated reaction against thyroid-stimulating hormone receptor with the orbital fibroblast modulation of T-cell lymphocytes. T-cell lymphocytes are believed to react against thyroid follicular cells with shared antigenic epitopes in the retroorbital space, and an active phase of inflammation initially presents. Lymphocytic infiltration of the orbital tissue causes a release of cytokines from T cells, stimulating the orbital fibroblasts to produce mucopolysaccharides, which by hemoosmotic shift causes tissue edema in the extraocular muscles. The cytokines activate previously quiescent fibroblasts to secrete hyaluronic acid, a glycosaminoglycan, which by doubling the hyaluronic acid content in the orbital tissue, it causes a 5-fold increase in tissue osmotic load. In addition to that, pre-adipocyte fibroblasts are influenced to transform into adipocytes, especially in young patients. Now, this is an illustration of the Bartley's diagnostic criteria for Graves' ophthalmopathy, also known as thyroid eye disease. Thyroid eye disease is considered to be present if eyelid retraction occurs in association with objective evidence of thyroid function or abnormal regulation, exophthalmos, optic nerve dysfunction, or extramuscular involvement or extraocular muscle involvement. The ophthalmic signs may be unilateral or bilateral, and confounding causes must be excluded. If eyelid retraction is if eyelid retraction is absent, then thyroid eye disease may be diagnosed only if exophthalmos, optic nerve involvement, or restrictive ocular myopathy is associated with thyroid dysfunction or abnormal regulation, and if no other cause of ophthalmic feature is apparent. This is the clinical activity score by the European Group of Graves' Ophthalmopathy, or UGOGO, and it's based on the classical signs of acute inflammation such as redness, pain, swelling, and impaired function. It was proposed as a clinical classification to discriminate easily between an active and an quiescent stage of the disease. 1 point is given for the presence of each of the parameters assessed, and the sum of all the points defines the clinical activity. Active ophthalmopathy is present if the score is above 3/7 at the first examination or above 4/7 in the successive examinations. That's why this is very important when you're thinking of the activity of the disease and when you're going to intervene with surgery or still with medical treatment. So what are the reconstructive surgeries available to thyroid eye disease patients? There are 4 main stages of surgical rehabilitation. First is the orbital decompression, then the strabismus surgery for double vision, then eyelid retraction repair and blepharoplasty. In general, if orbital decompression is needed, it has to be performed before the EOM or eyelid surgery because it has an effect on both extraocular muscle balance and eyelid positions. The last surgical stage, blepharoplasty, is sometimes referred to as the touch-up phase or touch-up stage to improve the overall appearance and the feel of the eyelids. So now I'm going to be talking about the case. So the background discussion of thyroid eye disease is finished. Now we can continue with the case presentation, focusing on the evaluation of aesthetic rehabilitation of thyroid eye disease. Just a reminder to our listeners tonight that the patient has signed a written consent as well as a verbal consent, allowing me to show her entire face for the conference tonight. So we have to talk about the normal anatomy of the eyelid at presentation before we can differentiate it from what's abnormal. So first, we look at it from primary gaze, the ocular alignment, and we use the corneal light reflex or the Hirschberg reflex to know if the eyes are aligned. So normal alignment means that the reflection will appear in the same position in each pupil, and misalignment of the eyes shows the location of the corneal reflex will appear asymmetric and off-center. Another vital sign of the eyelid is what we call the marginal reflex distance, 1, which is the distance between the corneal light reflex and the upper lid margin. And the normal value for this is 4 to 4.5 millimeters. The second marginal reflex distance 2 is the distance between the corneal light reflex and the lower lid margin. And normally it's 5 millimeters. The sum of the MRD1 and the MRD2 comprises the vertical palpebral fissure or the vertical height of the eyelid opening. The horizontal palpebral fissure normally is around 23 to 30 millimeters in diameter. Also pay close attention to the lid crease height. For Asians, it's usually 4 to 5 millimeters. For the orbital fat pads, you can see that the upper eyelid is divided into 2 components, the pre-aponeurotic central fat pad and the medial fat pad. A portion of the lateral end of the central fat pad surrounds the medial aspect of the lacrimal gland. 3 retroseptal fat pads are associated with the lower eyelids. This also changes in the thyroid eye disease as proptosis plus the fat enlargement makes the eyelid appear puffier. Now we talk about exophthalmometry. The normal amount of ocular protrusion as measured with an exophthalmometer from the lateral orbital rim to the corneal apex is 14 to 21 millimeters in adults. Protrusion greater than 21 millimeters or 2 millimeters or greater asymmetry between the protrusion of the patient's eyes is considered abnormal. On scans, proptosis is defined as globe protrusion greater than 21 millimeters anterior to the interzygomatic line on axial scans at the level of the lens. So that's the example of Hertel's exophthalmometer. So now we proceed with our index patient, who is a 30-year-old female non-smoker diagnosed with thyroid eye disease last 2018 at Cagayan de Oro. She's allegedly allergic to medicines for hyperthyroidism, so she was hyperthyroid. She underwent RAI last August 2018 and noted an increase in eye enlargement at December of that same year. She then moved to Legazpi Albay, where she's managed by her endocrinologist since 2019 and was referred to the Legazpi Eye Center last July, where I saw her. She brought in these MRI plates. On axial cuts on the left image shows obvious proptosis for both eyes, as the posterior pole of the globe is at the level of the interzygomatic line on mid-orbital plane. The coronal cut on the right image shows very slight enlargement of the EOMs, and there were no crowding on the optic nerve in the posterior orbit. This correlates with the 20/20 vision on both eyes of the patient. So based on the Bartley's diagnostic criteria, this patient has thyroid eye disease. So she has lid retraction, she has thyroid dysfunction, she has exophthalmos, and she has the extraocular muscles are slightly involved. Okay, so according to the clinical activity score by the European Group of Graves Orbitopathy, the patient has an active thyroid eye disease. So for the physical examination, visual acuity was 20/20 for both eyes. And on gross examination, we noted lid retraction. We also noted von Graff sign, It is not shown here, but it is the lagging of the upper eyelid on downward rotation of the eye. There's also proptosis that I measured at 25 millimeters bilaterally using the Hertel's exophthalmometer. You note here on the picture eyelid puffiness, especially on the upper eyelid laterally. Okay, and there's also a lateral flare. If you note the shape of the upper lid margin, it's not only retracted, but superolaterally, it is there. There's like a flare curving, more lateral and superior, changing the almond shape of the eye. Again, the eyelids are puffy, and there's a lag of thalamus when I ask the patient to close her eyes. She had full EOMs equal, and there was no diplopia. The IOP was 19 and fundoscopy was normal. So this is a picture of the patient last March 2018, where before she had thyroid eye disease. And this is the picture that I showed you earlier, which was her first day of consult last July 2019 at Legazpi Eye Center. So what are the techniques for orbital decompression surgery? This patient, before the plan was to do, for this patient, our plan was to do a stage procedure for bony orbital decompression combined with fat removal, orbital decompression, and lid recession and lateral tarsorrhaphy after 1 month. So these are our options for decompression. We can do a bony decompression. This bony decompression may involve a single or multiple walls of the orbit. And we can also do fat removal. An average volume of fat is in the orbit is about 8 milliliters normally, but in thyroid eye disease, it may increase to 10 milliliters or more. Trokel et al. Demonstrated that an average proptosis reduction of 1.8 millimeters with orbital fat excision alone was achieved, and the greatest average reduction in proptosis was 3.3 millimeters in patients with preoperative Hertels of 25 millimeters. For the bony decompression, postoperative diplopia should be watched out for because there's a complication of an inferior globe displacement if you remove too much bone. So this must be avoided. And this can be avoided according to Paradaens et al. By preserving the inferomedial strut. Now, Dr. Kikawa et al. In 2002 developed or graded orbital decompression based on the severity of the proptosis. So they did lateral orbital wall decompression with orbital fat removal if the exophthalmos was less than 22 millimeters. They added a medial wall decompression if exophthalmos was between 22 and 25 millimeters, and a third wall decompression was added with the removal of the orbital floor if exophthalmos was greater than 25 millimeters. Now I'm going to show you a borrowed video from Dr. Milind Naik, who is a friend of the Philippine Society of Ophthalmic Plastic and Reconstructive Surgery. And this is a sample video of how it's done using a model. Okay, so here, Dr. Milind is using this bone model and removing the periosteum on the orbital floor to expose it. He's using a FREER elevator to fracture the orbital floor, the medial orbital floor, and he uses a Kerrison rongeur to enlarge the controlled fracture. You can see the inframedial strut was left intact. This is to avoid the severe enophthalmos post-operatively. You can see that the yellow clay anatomical structures represent the infraorbital nerve inferiorly and superiorly. That's already the maxillary sinus, and the suction is being used to remove, for example, intraoperatively blood. He's continuing at the posterior wall, the posterior part of the orbit. Now, he's using a transcaruncular axis to the medial wall. He lifted the periosteum, and he's now using a Kerrison rongeur to enlarge the medial wall fracture that he created using this rondure. So I only showed this part of the video because this is what I intended to do for the patient. So this is the patient, intraoperative pictures, but before the surgery. Although many authors use the term cosmetic decompression, it must be kept in mind that this in fact represents reconstructive surgery because it addresses an abnormality caused by the disease. While decompression surgery has the potential to improve the facial appearance of the patient, they should be carefully informed that this is often impossible to restore their look to that what it has been before the disease began. So this is the actual photo of our patient showing the floor decompression, showing the controlled fracture that we created. The yellow line is pointing at the infraorbital nerve. So when you open the orbit, that's on the floor rather, the floor of the orbit, that's the first thing that I look for because a complication would be harming this nerve and causing numbness on the lower eyelid, the cheek, and the upper lip, and even the gums on that same side. As you can see, what's different from my technique is not only do I create decompression on the floor on the medial aspect, but also on the lateral aspect. I use a bone gouge so that sometimes the lateral aspect is a little bit harder. And I found it very stable and it did not cause any diplopia on my patient. I just need to be very careful with the infraorbital nerve. So you can see the maxillary sinus, the white mucosa, and it's around 30 millimeters deep when you put your suction. So this is the medial side, transcaruncular approach. We did a medial wall decompression and we removed the anterior part of the ethmoid bone. We exposed it using a FREER elevator and a malleable. And like I said, we did not go too posterior to avoid the risk of possible diplopia in the future. Sometimes other surgeons do that, but not for aesthetic. Rather, they do that for decompression in patients with dysthyroid optic neuropathy, where the thyroid eye disease is already compromising the vision of the patient. So this is a photo of the removed fat from the left and the right orbit. Approximately 2 to 3 cc's of fat was removed per side. So now you can see on July 4, the first day of consult on the left. On the right is a 2-week post-op picture of the patient post-orbital decompression. You would notice that there are bruising still, but the lid retraction has already decreased. We did, I forgot to mention, but I showed it on video, that we did a transconjunctival approach after a lateral canthotomy cantholysis. So the incision is very small on the skin. Now, what are the things that you will observe here on this patient? You would note that on the right side, the right picture on the right eye of the patient, you would note that there is more lateral flare compared to the left. That's why it's very important to proceed with the eyelid surgery after several months. So now, this is a picture on the left of the patient 2 weeks post-op and comparing it to the right picture, which is 1 month post-orbital decompression last August 2019. You would note that the bruising was gone because this is already 1 month post-op. The swelling subsided a little bit. There is still a little bit of lateral flare on both sides, being more on the right eye, I mean. So now I'm comparing the patient's first day of consult on the left, last July 4, to the first month of post-decompression. So there's already a very big difference in terms of the stare of the patient. It has really improved just with orbital decompression, just by doing a 2-wall orbital bone decompression plus fat removal decompression. I also, by the way, I also injected 4 milligrams of dexamethasone on each orbit immediately after the surgery before I closed. I'm just showing you this case because the next step after this patient, our index patient's next step is the eyelid surgery already. I'm just showing these patients because these patients are also post-decompression. I did this patient almost 3 weeks ago, but this is already a 2 weeks post-op on the right picture. You would notice that the patient's lid retraction decreased and the lateral flare is still there, but you can already see that the scleral show for both upper eyelids above the limbus for both eyes have significantly decreased. Okay, so I had the privilege of sharing this with our fellow and our resident, and we were lucky to do a back-to-back procedure to compare the difference between the two patients. You can see here on the right picture, there is lid retraction. However, there's no scleral show, but there's eyelid puffiness and there's lateral flare, which is a very early clue for ophthalmologists to suspect if the patient has early or mild thyroid eye disease. Post decompression on the right, you can see that the lid recession did decrease. I mean, the lid retraction did decrease, but we still plan to do a lid recession after a month. The difference between the first patient and the second patient is that the second patient has had a thyroid eye disease since 2017. So this patient had longer disease compared to this patient, where she only had it last year, and she even had a thyroidectomy last June. However, both of them are quiet or inactive based on the UGOGO clinical activity score. And I will have an insight on this later on in the talk. So this is a picture of the patient intra-op. The left side shows pre-op, where you can see congestion of the eye with significant forward displacement of the eye. And on the right picture, you can see that the globe is now less congested, less red, and you can see a significant retro displacement of the globe just after a two-wall decompression and fat decompression. You can see the incision here with the sutures is really small. So now we're going to talk about lid recession. This is an example of a patient that only has lid retraction but no proptosis. The reason why I'm showing this picture is because I was able to document the lid recession surgery. So this is an inverted eyelid of the patient's retracted eyelid. And you can see that I've incised the conjunctiva. And after incising the conjunctiva, I actually incised the Mueller's muscle. And I used an iris repositor, which we use in eye surgery. And the key there is to lift the Mueller's muscle and incise it upwards so that rather than using a knife or a radiofrequency unit to avoid injuring the levator aponeurosis. So I actually harvested a donor tarsoconjunctival graft from the contralateral upper eyelid of the patient. And you can see here that I filled up the space between the edges of the wound. I sutured it with a 10-0 chromic suture, which melts in 10 days, which is most ideal. And I put a bandage contact lens. That is to avoid to avoid damaging the cornea. So this is immediately a day post-op after the lid recession on the right, from the picture on the left. And you can see that there is no more scleral show. And We did not have to do a lateral tarsorrhaphy for this patient because the patient is young and the almond shape integrity of the eyelid opening has been maintained. Now, I'm just sharing you this patient because you will notice here that if you don't do a lid recession procedure, this is what it will look like. But I did a decompression procedure here on this patient because the patient was referred to me by her endocrinologist coming in with a vision of hand movement. So I did an orbital decompression here for this thyroid optic neuropathy rather than aesthetic rehabilitation. Post-op, you can see on the right picture that the lid retraction has decreased, but there is still some more on the right than the left. The congestion in the eye has been reduced significantly, but the most important thing that we have luckily achieved is that the patient's vision was already 20/40, 2 weeks after the surgery when I followed her up when I came back to Legazpi. So the patient's very happy, but she did not opt to do the aesthetic rehabilitation. Now, this is our patient last January 2020. We did the lid recession, and this is 1 day post-op. You can see that the lid recession improved the lid retraction. There is still redness and swelling on both upper eyelids. And comparing her with her 2 weeks post-lid recession, where the upper eyelid is no longer swollen, and you can see that there's really significant reduction in the vertical palpebral fissure. Now, she's very happy, and this is a comparison of her 1 month post-orbital decompression on the left and 2 weeks post-lid recession after several months. Now, this is her first day of consult, comparing it with her 2-week post-decompression picture, and this is her 2-week post-lid recession pictures. You can see the difference really from the pre-surgery and the stage surgery that took several months. And then COVID-19 pandemic happened. So I did not see the patient for a while. And now, luckily, we already had vaccinations. This is her last March 1, 2021, 1 year and 8 months post aesthetic rehabilitation. And you can see that the contour of her eyelid has been restored a little bit, of course, not like what she looked like before, but there's really a dramatic change in terms of the stare, the contour, the puffiness, and the lid retraction and proptosis for this patient. So if you talk to the patient and their families, you can really feel a sense of urgency to rehabilitate their appearance. As their doctor, we must explain the risks and benefits of having surgery for thyroid eye disease. Remember, these patients do their research to see what could be done for their situation. Some are willing to go abroad to have the procedure even during this pandemic time. They do consult several doctors locally, and they try to confirm if what they've researched is really doable. Most importantly, they seek compassion in us, that we understand that the physical changes that they're going through affect their daily lives. If we can manage their expectations with what we can deliver, they can gain confidence not only in the safety of the procedure, but in the potential improvement on how they look. So these are my recommendations for thyroid eye disease aesthetic rehabilitation. First, it's really important to emphasize that it is a multi-stage procedure. I would recommend to follow the graded orbital decompression based on the severity of proptosis as proposed by Dr. Kikawa. I will always preserve the inferomedial strut to avoid post-operative diplopia because this is the most common complication based on what's seen on literature, aside from the numbness on the lower lid and the upper cheek. I do not go more posterior, especially on the medial wall for aesthetic decompressions, as that is a risk, again, for inferior globe displacement, and those are reserved for these thyroid optic neuropathies. When you go in, transconjunctivally, you first identify the infraorbital nerve immediately if you're doing a floor decompression to avoid the said complication of numbness. And with the patient's consent, photo document each stage of the treatment. So as a take-home message, and I quote this verbatim from one of our teachers in medical CP, that we have to manage the expectations on what we can possibly achieve after the surgery. You have to be honest with the patient on the limitations of the procedure and the possible complications. You always have to stick to the science and be thorough in explaining the multi-stage approach of this procedure. And most importantly, be empathic on their condition and show them that we care about the results as much as they do. Thank you very much for listening.
Okay, thank you so much for that presentation, Ken. Thank you for sharing with us your cases. That was really an insightful lecture, especially when you showed us the preoperative problems of these patients and eventually seeing how much their appearance have improved after thyroid eye surgery. Again, for our viewers, you can type in your questions in the comment section. Stay tuned as we will be tackling each of them after this short break.
So now that our lectures have all been given, I think it's time to answer some questions from the audience. So for our first question, if considering surgery, who does one see first, the dermatologist or the oculoplastic surgeon? I think for this question, anyone can answer.
Actually, that would really depend on the situation of the patient because every patient is different. Usually, they'll talk to the ones that they know already. So whether if that's a derma or the ophthalmic plastic surgeon, who they're comfortable with. So there's no cookie cutter approach that they should approach this person yet, etc.
Yeah, I agree with Dr. Hamora. But in general, I mean, my personal opinion is whether the patient approaches the derma first or the oculoplastic surgeon, eventually she'll have to see both. I mean, even if the management is first surgical or first dermatologic, well, especially if it's surgical, from my point of view, like I said in my lecture, I always, more often than not, refer at some point to dermatologists because just like when Dr. Hamora said that the dermatologic procedures are not a replacement for surgery, it's the same thing when it comes from our point of view. The surgeries cannot replace some of the dermatologic procedures. Like we can do surgery, but the quality of the skin still has to be good. So post-operatively, um, I always like refer to dermatologists afterwards because aside from keeping the skin healthy and nice looking, they can also sort of maintain the advantages or the improvements that were brought about by surgery. You can't stop the aging process, but the dermatologists have a whole lot of things in their arsenal that can definitely slow it down and really maintain, the aesthetic.
Okay, thank you for that. I do have a question, no? So anybody can answer here. I'd like to know how soon can we do the adjunctive treatments, no, after we do the eyelid surgery? Maybe Dr. Hamor, you'll have a better opinion about this one, no? About the Fraxel and all those things.
Okay, so that's a good question. Actually, depends on the status of the patient's skin. Because as you know, we want to really just to prepare the patient for the surgery, as well as do the post-operative care that's required after surgery. So if you're going to have, for example, the blepharoplasty, you can actually have the pulse dye laser on the same day as the removal of the sutures. So that way, while it's still red, you can actually seal the blood vessels already. But at the same time, if you want to do like the other types of lasers and energy-based devices, actually, as dermatologists, we usually recommend don't do those treatments first on the inflamed skin, because you don't want to worsen the inflammation. You actually want to decrease it. So most of the lasers and energy-based devices, they produce collagen because there's a small process of inflammation. Mm-mm.
Okay. So
Yeah.
I also
So
have
What about the
sorry.
tightening procedure, Doctor? I'm sorry. Okay, sorry. Go
Yeah.
ahead.
No, for the tightening, actually, if for example you had the blepharoplasty already, if there's no more
Yeah.
swelling, he or she can have the tightening already. There's no limitation on that because it's on a different area. So, diba, this is the periorbital naman. Then you want to tighten the like the line of the jaw or the neck. You can do that actually if the patient is willing. In some places they do it at the same time. Kasi because of the time limitation. So parang limit na lang the downtime. So do it together.
Okay, thank you.
I think Dr. Bengzon was trying to say something.
yeah, no, I was just gonna say that I really enjoyed Dr. Hamar's lecture, and I learned something, a lot of new things. Like for example, I wasn't aware that you could use the pulse dye
Yeah.
within a
Yeah.
week after surgery. Like normally, when we remove the suture, and I'd see these signs of those blood vessels, the neovascular blood vessels. Uh, I didn't know that should be managed right away. Uh, Normally, I'd wait a couple of weeks because I was afraid that managing it with the pulse dye would affect the wound healing. I'm glad to hear now that it doesn't really affect it, and it should really be started within that week after the surgery. So yeah, thanks for that. Thank you.
Yeah, you're welcome.
Actually, I have another question to Dr. Chrissy. So, what is the role of thread lifts in the periorbital area, and to which patients do you suggest this kind of procedure?
Yes, that's a good question. Actually, thread lifts produce neocollagenesis also on those areas. So actually, threads, they have varying calibers also. There's 6O, 5O, 4O, etc. So depending on the caliber of the thread, it can, if it's very thin, like a 6O, it produces more collagen remodeling. However, the bigger caliber threads actually lift the skin. So again, it's like depends on what hammer you use. So some people they want the thread because they saw it on the internet or their friend had it. But others they prefer non-invasive treatments because of course when you're doing the threads, there's punctures, diba, on that area. Mm-mm.
Okay, great.
So we have questions.
Uh,
Okay, it's not showing it. So I do have question also for Doc Resina. So one of the most devastating adverse effect of injecting your fillers would be your occlusion, right? Get your ischemia, necrosis, leading to necrosis. So do you have any recommendations for us, like as to how to prevent this, like when we're putting the fillers or injecting the fillers?
Yeah, exactly. So first you have to have your emergency toolkit. So basically, every time you inject fillers, you have to have hyaluronidase. And then basically what you need to do is when you're talking to the patient, you tell them, is there any pain? Is there any discomfort? Because if there is already a sudden pain, that's already a red flag. So at that time, if they feel the sudden pain, like they flinch, maybe you're near a blood vessel or a nerve. So withdraw the needle right away. And then if the patient says, oh, it's still painful, then you already inject the hyaluronidase at that area. So the sooner you inject the hyaluronidase, the faster you can melt the hyaluronic acid. However, there are some fillers that you really can't melt, like your polylactic acid or your calcium hydroxyl apatite. Those don't have a remedy. So, unfortunately, those kinds of, if they do go into the blood vessel, there's nothing that you can inject to lessen the effects.
Okay. Anybody else? Do you have questions
We have
now?
another question. I think yeah, this is for Dr. Lagunzad. So will the exophthalmos resolve if you resolve the thyroid hormone?
Okay, thank you for that question. Can you hear me?
Yes, we can hear you, sir.
Yeah, so the obvious answer is no, because these patients who have most of the time it won't, because these patients who have inactive thyroid eye disease, even for years, still have this proptosis, no, even measured on scans or with Hertel's exophthalmometer. So if you do, for example, a lid surgery for a severely proptosed patient with an inactive thyroid eye disease, it won't really work. So those patients would really need decompression, and an attempt to do a lid surgery just to temporize the lateral flare will really show, because these patients are still proptosed. So that's my answer.
Okay. So we have another question. Okay, so here, what are the risks or limitations and advantages when comparing fillers versus grafts versus fat transposition surgery? So anybody can answer this? Who wants to go?
Ladies first.
I can do the first part. Okay, so
Ladies first.
like for fillers, as we know, it's temporary. So we have to emphasize that to our patient. It does not replace fat transposition. So if they want something that's long lasting, I would refer to our ophthalmic plastic surgeons, because they can give them what the patient wants. So knowing what your patient wants in the end ultimately makes you decide what to use. So if they will accept something permanent or only something temporary, so they have to work with them so that they'll be happy. Because otherwise, if you tell them, oh, let's just do this na lang because I have it here ready, they won't be satisfied. Sayang lang. So let them save their money and go na lang to the ophthalmic plastic surgeon.
Dr.
Yeah.
Bengzon?
Yeah. I in the past, before the latest fillers or the newer fillers came out, I wasn't a big fan of fillers, and the reason why is, I think Chrissy mentioned it. The older fillers were really heavy, and they had a tendency to in time create sausages and scars, and then weigh down. So I've seen patients who were injected like decades ago, and then they come in, and because of the age and the gravity and all that, it's impossible to excise those hardened fillers. We don't get that anymore with the current fillers, and that's why nowadays, when I see a patient who I feel would benefit from a filler, uh, I would that's where I would sort of push them first before discussing surgery. And because if they use the filler and they're happy with it, then that's great. And if they're happy with it, and then after a few months to a year, uh, the filler effect goes away, then they have that option of having the filler again, or then doing surgery, which would be longer lasting. At least nakita nila yung effect, that okay, that's how surgery would also do, but then it would last, what it could do for you, but then it would last longer, diba? And then by that time, they're usually used to that dynamic between the surgeon and the dermatologist, that team, and the trust is there. So when they get good results, they're more likely to believe you and come back to you, and be more open-minded to other options. Fillers as well, and the advantages of fillers is they can be reversible if something adverse happens, and surgery has its own advantages as well. So, like for example, those two patients I showed you, that I believe they would have benefited from fillers, but given the options, they made their own decision to go with surgery. Um, and they had their own reasons. I think one of them was they weren't based here in Manila, and they didn't know when they'd be able to come back for a repeat injection. So they wanted something longer lasting. So they went with the surgery.
Okay, so I think this will be our last question. So, what is the best way to manage or to prevent or manage post-operative blepharoplasty incision lines? I think maybe anyone can answer this question.
Yeah, I think that
So,
was answered by Chrissy, but yeah,
Yeah.
Chrissy. Go ahead.
yeah,
Okay. Yeah. Actually, the best way to prevent is to have first good skincare around the area before the surgery. But for example, the patient doesn't have time to put skincare anymore. Like they're only here for 1 month. Like a lot of our balikbayan patients, they only come for a month. Then at least send them home with skincare. And then also you can do like 1 or 2 laser sessions after the blepharoplasty. So if the time is limited, then we have to do that quick treatment plan. So pre-op evaluation, surgery, laser, skincare. However, if the patient's here and then time doesn't matter, it's really easier for the surgeon if there is already skincare on that area, so the healing is faster, less pigmentation. So, for example, if you start with those topical medications around the eyelids, you won't have as much post-inflammatory hyperpigmentation. And then that way, the surgical result will be nicer, faster. So instead of having like pigmentation on the patient's skin, because Filipinos, Asians are prone to that redness, which can translate to brown line on the incision site.
Okay. So I guess that's all for our questions for today. So it makes us all happy to see how interested our audience is in our topic today. I believe actually this is one of the most interesting episodes to date since the topics are applicable to both ophthalmologists and dermatologists as well. Right, Reg?
yes, Dr. Evie. So, as this episode comes to a close, we would like to thank our speakers today, Dr. Dim Homora, Dr. Bengzon, and Dr. Lagunzad. Of course, we would like to thank all of you for joining us today. We hope you learned as much as Dr. Evie and I did.
Yeah, I know I did learn a lot from this episode. So, Reg and I hope to see you again when we host here on TMC ITV. And for our next episode, we will focus on the use of cyclosporin on ocular surface disease. Our friends from Cornea and External Disease section will be back to take over and give you another great show. See you all on November 4 for episode 19 of TMC ITV.
Again, I'm Regina Valencia.
And I'm Debbie Shapno. Thank you for joining us today. And thank you to our sponsor, Allergan, for doing this episode with us.
Stay safe, and we hope to see you in the next episode of TMC ITV, Ophthalmic Instruction Without Borders. Good evening, everyone.
Evening.
When a healthy tear film becomes unstable, your patients can become trapped in the vicious cycle of dry eye disease. Optiv Fusion's Power of 3 could help you do more for your patients. OptiFusion contains osmoprotectants, hyaluronic acid and carboxymethyl cellulose, which work together to target tear film instability and combat dry eye disease.
I'm a fixer, one of the osmoprotectants in OptiFusion. I target hyperosmolarity and help halt the vicious cycle of dry eye disease. I restore cell volume and protect ocular cells against hypertonic stress.
I'm the carer. While the fixer gets to work, I lubricate the ocular surface to soothe dry eye symptoms and increase tear film thickness to protect against evaporation.
I'm the anchor. I'm known for my excellent comfort skills, but I'm also one of the strongest mucoadhesive polymers around. I bind to corneal cells and increase retention time on the ocular surface to provide comfort and maintain symptom relief.
Together, we work to fight dry eye disease. Recommend OptiFusion's Power of 3 to your patients today.